I'm going to go ahead and introduce the team that shall be leading the discussion today. Could we have Joseph introduce himself?
Yes, good evening, everyone. Thank you, Dr. Tira, for the initiative. My name is Kalimzo Joseph. I'm a Year 5 medical student, and I'll be your case presenter today. Hope we can benefit from this discussion. Thank you.
Thank you so much. Let's have Aukasha. Kusewo. All right, looks like Kusewo is still not on call. Let's have Jacob, Dr. Jacob, and go ahead and introduce yourself.
Yes, doctor, I'm sorry. Good
Okay.
evening, everyone. My name is Kuseo Kasha, and I'm emergency medical technician student at Rubaga Hospital training school, and I'm going to be your pre-hospital presenter today.
Thank you, Aukasha. Let's have Dr. Jacob.
Yes, good evening, everyone. Hope you're all well, and welcome to this session of the clinical pathological cases. I am Bosinje Jacob. I'm an emergency physician at Timbara Regional Referral Hospital, but also the university, and I'm glad to be part of the discussion today.
Thank you. Good to have you, Dr. Jacob. We are very excited and we are very expectant to listen to the discussion that is going to take place. We are going to be diving straight into the discussion for today, and we shall be looking at approach to a decompensating trauma patient. If you're all aware that trauma is among the 5 killer diseases currently, and if not, it's actually like the most common condition that you're going to manage in the emergency department. At least if you're going to be working in an emergency department on any day, you are not going to work the whole day without seeing a patient of trauma. It could be because of a road traffic accident, could be because of a fall, could be because of sports, a lot of things that could cause us trauma. And that is the discussion that we're going to be having. How do we approach that trauma patient that's decompensating? And Kuseo alongside the Kalimzo has prepared for us a case for this discussion today, and I'm going to hand over to Kuseo to take us through the first segment of the session.
Yes, a very good evening to everyone. As I introduced myself, my name is Kuseo Kasha. I'm the pre-hospital presenter today. Our case today, we have a 48-year-old male who referred to a peripheral clinic and was reported had received fallen from a height, and thereafter developed a severe back pain and inability to walk. Another slide. And in this case,
so we have a poll question for you that's going to be launched to your screen. This is basically just to help us engage with you and also help us to know how you would approach this patient. If you were that EMT that was called to go and pick up this patient with a history of a fall from a height, what would you do? What must you carry as you go to pick this patient? So there is a poll that's going to be launched on your screen. Please take time and respond to it. And the question goes, if you are the EMT called to pick up this patient, what must you carry? Patient who has, let's say, has fallen, is not able to walk. What other things might you expect in that patient, and what precautions must you take as you are going to pick up this patient from the scene of the incident? What exactly should you be thinking about? What are the emergencies that should be running in your mind as you go to pick this patient? Thinking about the potential emergencies would, of course, trigger you to think about certain things that you might need if you're going to be able to respond to the emergency that you might encounter as you go to pick the patient. I'm still seeing only one response. Please respond to the poll on your screen. So we have options. Do you think priority things for you is blood pressure machine, glucometer, bandages, urinalysis dipstick? Or do you think? Oh, someone is saying they. Okay, I think someone ended the poll. Let me relaunch it. Sorry, I'm going to stop sharing and then relaunch the poll. Oh, sorry, someone had the. Okay, this is not. So let me reshare the poll for us. Oh God. So sorry. Let me get back and relaunch the poll. This doesn't seem to be working. Okay. So I don't seem to figure this out. All right, I think we shall just go on to the next slide. We shall be able to, I think, engage in the next poll question. This has not worked out. Can someone see the poll questions now?
Yes, the poll question is now on and people are answering.
Okay, I'm going to give us 30 seconds to respond. Let's be fast. After which we shall then move to the next slide. And again, to notice that in Uganda, we still don't have sufficient EMTs who can go to pick the patient. So even a medical officer could actually be called to pick up a patient from the scene of incidents or from their home. If the facility has maybe an ambulance and the patient needs to be brought to the facility, you could actually be that doctor whom they are going to pick on. You could be that EMT who is going to be sent to go and pick up such a patient from the scene of incidents or from their home. All right, I'm seeing 27 out of 30, so I think we're going to go on. I'm going to end the poll and we carry on with the presentation. Let's go on.
Yes, thank you. Yes, thank you, doctor. So in this case, we shall need a minimum of 2 EMTs and 1 driver to respond to this case. We have 1 patient to respond to. The requirements that might be needed in this response: we need communication devices to communicate during transport of the patient and to the facility where we are taking our patient to. We shall need a C-collar to immobilize our cervical spine. We shall need a spine board and its accessories due to the mechanism of injury we got. Remember, we had gotten a fall from a height, so we suspect a spine injury. In this case, we shall need a spine board and its accessories. We shall need diagnostics like a stethoscope, a BP cuff, a pulse oximeter, and large bore cannulas. In case of drug administration, we shall need paracetamol 100 mils as our painkiller. We shall need a non-rebreather mask for oxygen administration and clean gauze in case of wounds or bleeding to clean the wounds and arrest hemorrhage, and a blanket to minimize the risk of hypothermia. In this case, we shall need a type B ambulance. That's a basic life support ambulance to respond to this case. And when we reach the facility, we shall have to give a report I'm requesting for another slide. In the report, my name is Kuseo Kasha. I'm an EMT handing over a 48-year-old male with a history of a fall from a height. The patient presented with a sharp back pain, rated 10 out of 10, and inability to walk. The patient was alert and able to coherent. On background, a patient was referred from a peripheral clinic after falling 40 meters off a tree, landing on his right side, right and back, resulting into inability to move with intact sensation. On assessment, we had a respiratory rate of 24 beats per minute. We had warm peripherals. We had a pulse rate of 110 beats per minute. We had a BP of 129 over 76 millimeters of mercury. Our temperature was 35.5 degrees Celsius, and we also due to our respiratory rate, we administered oxygen 15 liters via an rebreather. We administered paracetamol as our painkiller in this case, and we also had to insert a C-collar and a spine board to immobilize our spine. We covered the patient with a warm blanket to minimize the risk of hypothermia. And in this case, I would recommend our patient to meet an orthopedic and neurosurgeon for review. I would also recommend to do a spine CT MRI, all MRI, and also some labs like CBC. And also, we should keep the C-collar and spine board on the patient to minimize more risks of our spine injury. Thank you.
All right, thank you so much, Ukasha. I think he's handed over the patient to the emergency department. Safely, let's get to hear what happens to this patient in the emergency department. Over to you, Joseph.
Thank you. Good evening once again. So we received this patient, as Okasha had ably explained, and we had to perform ATLS with our primary survey. So under the airway, the patient had a patent airway as he was able to speak, and then under breathing, he had reduced chest movements, and we also noted that he had accessory muscle involvement on breathing. And then his respiratory rate, as had been mentioned before, is 24 breaths per minute, and he had a SpO2 of 85% on room air. However, it was we intervened with the non-rebreather mask. He had a tender chest wall and had dull bibacillar percussion note with reduced air entry and left intrascapular crackles on auscultation. So under circulation, he had warm peripheries, and his blood pressure was still at 129 over 76 millimeters of mercury. He had a heart rate of 110 beats per minute, and the peripheral pulse were present, as well as heart sounds were normal. Then under disability, we scored his GCS at 15 over 15. He had pupils equal and reactive to light. He was, however, not well oriented in time and place, and he also had noted lower limb weakness associated with
Joseph, I cannot hear you. I don't know whether it's the challenge is on my side. Anyone else who's able to pick Joseph? I seem to be struggling to get him.
Hello.
Okay, we can hear you now. Go ahead.
Yes. So I was saying under disability, his GCS was scored as at 15 over 15, and pupils were equal and reactive to light. However, he was not well oriented in time and place, and he had noted lower limb weakness associated with inability to walk at presentation. Then, when he was exposed, he had a core temperature of 36.5 degrees Celsius and had visible bruises on the right side of his body. However, we didn't find any concealed injuries or obvious bleeding. Yes, then we took a sample history, and for the signs and symptoms that he came in with, he had a painful back as described earlier, and he was unable to walk at presentation. He didn't have any known food or drug allergies and wasn't on any medications before admission. And under his past medical history, he didn't have any known chronic illnesses at the time of admission and was seronegative. And his last meal was about 7 hours before admission. And the event that led to this traumatic occurrence was falling from a tree while cutting branches at his workplace.
All right, so I think we shall turn back to the audience. We've listened into the presentation during pre-hospital care of this patient. We've also heard about the initial assessment that was done within the emergency department. And just to highlight is that the purpose for the primary survey that has been presented is to help us identify any imminent emergency or life threats that we need to sort as fast as we can so that we not end up losing the patient. Any information that you would want that maybe you think might have been missed or could help you to figure out what could be happening to the patient or what emergency you might be looking at in this patient. It's time for you to ask the presenters, the people that interact with the patient. Anyone can just feel free to unmute and speak. You have the rights. Any helpful information that you would want to know about this patient that has not been highlighted and you think might be important for the care of the patient? Okay, someone think is struggling to unmute, so I'm going to allow you. So you can try again. Try again to unmute. I've given you the rights to unmute.
The music.
All right. All right. If there's no question, no comment at this point. Someone is asking about bowel opening. Was the patient able to open their bowel? Joseph?
We did a digital rectal exam, and the anal sphincter was not loose.
Okay.
Yes.
Perfect. Yes, I see Jules. Jules and Melvin are unmute.
Okay, thank you. To ask you, did they perform any first ultrasound to see any, like focus ultrasound, see any intrathoracic bleeding? Because they say that the percussion was done on the chest. And how was the saturation and how was the intervention? Because it is not documented in the on the side of B and on side of B. And sometimes the focus ultrasound, like in case of fast, it can be also done on C. That is what I'm asking. Thank you.
Thank you, Jules. I think that's a very good question. I think on ultrasound, there is a segment that tells us about investigation that I think it will be able to highlight that. However, I think for the remaining questions, Joseph, you can go ahead and answer. All right, if you're going to mute, please only mute if you're asking questions or making comments. If I've asked you to. All right, Joseph, the rest of the question, I think you highlighted about the saturation that was at 80, 87, or 85.
Yes, it was 85 on room air.
Okay. All right, I think let's go on to the next slide. So it's time for us to get to hear from our expert in the house, Dr. Jacob. What are your initial opinions at this time about this patient? Any additional thoughts that you would want to highlight concerning this patient that we have in the emergency department with us? Over to you, Jacob.
Okay, thank you so much, Jimmy. And thank you to our pre-hospital and emergency department presenters. So this was a 48-year-old male who fell from a height. It was noted that this height was as high as 40 meters, which is a significant distance to fall from. And his thoughts at this point is that that's a significant mechanism of injury. Hello? Jimmy, was that you?
Okay, I think I've given people rights to unmute. I'm going to withdraw it so that I only unmute people when they are supposed to speak. Go ahead, Dr. Jacob.
I can. Okay. So the pre-hospital. I'll start from the pre-hospital for process, since that's where we started from. So this person who was unable to walk after falling from a height, we really planned very well when we were called from this peripheral health center to go and pick up this patient. We planned everything we thought we needed. Just a little bit of tweaks that I could have possibly done different or advised to be done differently. Despite the fact that when you reach the person, they were alert, talking to you, initially seemed to be saturating okay. But this is a risk, is a very dangerous mechanism of injury. So I think we could have gone with a different kind of ambulance. Yeah, we could have gone with our type Cs. If depending as we improve our national ambulance system, this is the kind of person who is at risk of very many other things that you could find at the scene that he's much sicker. But for this one, it seems this worked and was appropriate for that time. But because of their nature of injury, from the start, you go with what you think would be able to best help this patient because of what I said at the start, that it's a high risk of injury. So a lot of things could be concealed. A lot of things could be obvious to you once you reach the person, and you may need a higher level of ambulance. The other comment is also the type of analgesia, because if you fall from a height, you can imagine this guy was cutting branches at the workplace. Okay, there's risk of injuries all over the body from the head to the toe. Yeah, so he could be in great level of pain. So we have to be able to plan a stepwise manner of analgesia. And I think we had planned to go with paracetamol, and must have been sufficient for him. But I think I would have gone or planned to advise someone to go with a higher or a stronger analgesia for this patient. But otherwise, the pre-hospital plan was good. Yes, we needed a minimum of two EMTs, the C-spine collar and the spine board, to be able to respond to this person, because we are correctly thinking about the fact of spinal injury, and that was very well done. When they came to the emergency department, that was a beautiful handover that was done between the pre-hospital and the in-hospital team that was waiting for the patient. Our assessment revealed that the person had a reduced air entry with left subscapular cracks, if I'm right, and but the GCS was maintained. If this could be clarified, it seems initially the patient before transport had an SpO2 of 95. Now in the emergency department, it had dropped by 10 points to 885. Yes, and so just on that, I think we are having now, from the assessment now at the emergency department, some injuries are starting to reveal themselves, like a possible injury to the chest, like a hemothorax that is possibly causing the person to have a reduced air entry with those crackles on that side. But the GCS is still intact. We mentioned that maybe they were not concealed injuries, and we may not say that with a lot of certainty at that point, because like one of the questioners earlier asked, did we do a focus? And some of the things may not be obvious to you at the time. So we usually don't like in the first assessment, which we are calling a primary survey, which can actually be repeated several times to be able to jump to the conclusion that, oh, we do not have concealed injuries, because concealed means, oh, they are not jumping out at me. I'm not seeing a broken limb. I'm not seeing obvious bleeding, but there could be bleeding in the abdomen. but maybe at that point you're comfortable that they are not concealed. So to say it, there are some things you may need to have done, maybe like the podcast, CT for someone later on, depending. And then we also mentioned about someone asked about bowel opening, and in our exposure, I think the other thing we would have added was a nice choreographed log roll, which we usually encourage to be able to, because we're already thinking about this person who has fallen from a height. They are at risk of hurting several organs: the head, the neck, the chest, the abdomen, the limbs, the long bones. But mostly we are concerned about cervical spine injury. So the log roll has to be done very well and choreographed. And I think it was done. Maybe it was not stated here because you mentioned that we did a dictal rectal examination. Yeah, so far those are my thoughts. And yeah, so I just wanted to understand if there was an actual deterioration from the 95 SpO2 on the scene to now in the emergency department down to 85, if a log roll was done. And yeah, and it seems there was no loss of consciousness at any point. Yeah, for now, that is my thoughts. Thank you.
Awesome. Thank you so much, Dr. Jacob. I think those are very interesting thoughts. And I think I'm also seeing interesting discussions going on in the chat. Please go ahead and post your question, post your comments in the chat. You'll be sure to get them attended to, but also they will be able to help you trigger your thinking towards what could be happening with the patient as you interact in the chat as well. I will go ahead and do that. And someone has posted for us a video, a YouTube link to some interesting video that you can watch. Over to Joseph to continue with the presentation.
Thank you, Dr. Jimmy. So this is just a continuation from the primary survey. So this is what we did in the ED to intervene the different problems we encountered. So under the airway, we had said this airway was patent, but he was still showing signs that he's having difficulty in breathing. So we inserted a C-collar to protect the cervical spine and elevated the head of the bed. Then under breathing, we administered a non-rebreather mask, 15 liters, and his SpO2 improved to 95%. And under circulation, we inserted a large bore cannula with an IV bolus of 1 liter and also paracetamol, concentration of 1 gram. And then we inserted a urinary catheter and we took samples for blood, for grouping, and cross-matching. Also, the catheter was used for monitoring the fluid balance since we were giving him the fluids. Then under disability, as I had said earlier, he had confusion. So that's why we re-evaluated 14 out of 15 because he was not well oriented in time and place. And then he was immobilized still to protect the spine from further spinal injury using the spine board. And he was also received with a wheelchair at the emergency. Then under exposure, we kept him warm by covering with a blanket. And as doctor had pointed out, we had also performed the log roll to look for any superficial concealed injuries. Then under the secondary survey, this is where we did the head to toe. And from the head and neck, we did not have any significant findings as there was a non-tender neck and it was soft. We also, and the chest is where we had some of the significant findings, where we had a symmetrical chest expansion. We also had noted bruises to the right chest wall and generalized tenderness over the chest wall. We also still had reduced air entry and the occasional bibasal crackles. Then in the abdomen, we had normal fullness. We had right upper quadrant as well as right flank tenderness. Otherwise, on percussion, we had a normal tympanic percussion note and bowel sounds as well were normal. In the extremities, we didn't have any danger signs, and the pelvis was stable with no associated limb length discrepancies. Then under the skin, we did have multiple bruises, and they were more on the right side, and also a few wounds on the shoulder and elbow. Next slide, please. Yes, then we went in to do some investigations. We did general investigations first with a CBC, then also the blood which had been taken for crossing and matching, and then we also had an RFT. So under CBC, we had the notable findings were mainly low eosinophil count of 0.03, and the hemoglobin was normal, as well as the platelet count. Then from the blood group, we found that he was O positive, and the RFTs, we carried out the RFTs because he had also, on the assessment, we found that he had complaint of the right flank pain. So we're trying to rule out any acute kidney injury, and the parameters came back normal for the RFTs. Yes, from this we proceeded to imaging, and in the imaging, he came with a chest X-ray from the peripheral clinic, and this chest X-ray showed us bilateral lung contusions and pleural effusions, which are marked by the blunted costophrenic angles, and you can see it's a bit more pronounced on the left side, left lung field. Next slide, please. Yes.
All right, so we're going to have our second poll. Could we go to the next slide, which has the image? There's a slide with a CT scan image. Should be the slide that is following this one. Emma, could we go to the next slide so that people can get to see the CT scan? All right, so yeah, so that was the CT scan that was done for the patient. And at this point, we want just to pick your mind on what are the possibilities in the CT scan. As you see it, what are those injuries that you're able to elicit from this CT scan? Shall give us about 30 seconds, then we shall end up poll. So let's respond. Still seeing only a few responses. You have the poll on your screen. Just go ahead and respond to them. I still see very few responses. So the question is asking name and locate the injury in this CT scan. Could you be seeing rib fractures, spine fracture of T7, T10, pelvic fractures involving the iliac crest, compression fracture of L2, L3? What are you able to elicit from this CT scan that's being displayed? Okay, I know some people are still really studying so that they give the correct answer. For the sake of time, we are going to go ahead and end the poll so that we can continue with the presentation. We shall get to know what the answer was towards by the time we end this discussion. Over to you, Joseph.
All right, thank you.
Oh, okay. So I think it's actually time for us to get to hear from the experts. We have listened into the primary survey, we've listened into the secondary survey, the sample history, and also the investigations that were done. What could be in your mind at this point? How would you guide us on how to approach this patient? What is the problem? How is our problem list standing? What sort of differentials are we thinking about in this patient, and how should we plan to manage this patient? Over to you, Dr. Jacob.
Thank you, Jimmy. Very good work done so far. We have gone through from the pre-hospital, a primary survey has been done, a secondary survey has been done. At this point, from the initial presentations, I will start actually from head to toe, because since the patient since we started interacting with this patient, was initially 15 out of 15, he's now 14 out of 15. There's a possible differential of a head injury. There's inability for him to move his limbs, so we have possible spinal injury. We also have a possible chest injury, actually, that has been confirmed by our X-ray that we did. We saw those things, those patchy white on that chest X-ray that indicated the pulmonary contusions. It means he's bruised on the inside of his lungs, and also he's collecting some fluid because possibly of the injury that he got from that fall. So pleural effusions, lung contusions, head injuries, spinal injuries. Okay, it was not the exam did not reveal any pelvic or long bone fractures. Yeah, so those are the current injuries I'm going with. For the management plan, we are still going to manage the patient because we have already started the management. Actually, we have started with analgesia. Okay, we have given the person analgesia. Our gram of paracetamol was given, and we have to assess, has that actually helped our patient? If we reported that the person came in with a 10 out of 10 pain scale, are they better? Do we need to escalate our pain management? Now that we are thinking of head injury, we are going to raise the person's head to prevent problems of what? Increased ICP, because we are thinking that, oh, maybe since he fell, he may have hit his head and is collecting some blood in his head. Okay, so you may raise the head of the bed. Okay, you shall pass 2 large bore cannulae and take off the samples that have actually been taken off in the presentation before. And we can also prepare blood because this person who has fallen from height could possibly have concealed bleeding that maybe we have not yet discovered. So I would ask for grouping and cross-matching and have blood ready on if I want it. Okay, I'll manage the pain, raise the head of the bed, and there was a issue of that was mentioned of that in the emergency department we continued the spinal immobilization with the board at this time, and I don't know if I'm correct on that one, but I remember seeing that in Dr. Joseph's presentations. So if that was done, what I would change is that I would put the board off now, but still maintain his collar until I can clear that C-spine. So I would take the spine board that is lying, that hard surface that was used in the pre-hospital transportation. I would actually now put it off. I wouldn't keep it on him in the emergency department. Okay. Yeah. And so I would start some slow fluids. It did not seem to have any signs of shock at the moment. So I would manage his pain, raise his head, and be able to book and cross-match his blood and put him off that spinal board with those differentials in mind.
Thank you, Dr. Jacob. I think those are very interesting thoughts. We're going to go ahead and continue with the presentation. Over to you, Joseph.
Thank you, Dr. Sinja, and thank you, Dr. Jimmy. Yes, just what Doctor had said, these are the differentials that we came up with. We had traumatic spine injury being our first differential, and this was supported by history of a fall from a tree of 40 meters height, and then severe back pain, which he presented with, and a sudden onset of his inability to walk. Then we also had blunt chest trauma, and in this case, we were looking at the lung contusion, and it was evidenced by the chest pain, the diffuse chest pain, and also difficulty in breathing on examination. And then also I think of soft tissue injury, which was characterized by the multiple wounds that he came with, and also generalized body pain. And we did not have any contradicting findings.
Great. Thank you, Kalimuzo, for that. We have another poll question dropping in that is going to be shared in a few. And what the poll question is reading is, what is the mainstay specific conservative management priority for this patient? The polls are going to be launched soon, and we want to know. Yes, I think the polls are up, so we can get to answering that. Yeah, you can keep the questions coming in chat. Yes, we can give this about 30 minutes as you keep on answering the polls in the you keep on responding. Yes, I think we can end our quiz for now, and we can proceed with the discussion. Kalimuzo, over to you.
Thank you once again. So for the course of management in the ED, first we wanted to immobilize the spine using the C collar, and now as doctor had advised, we didn't require the spine board once he has been brought to the ED. And then for the breathing, we administered 15 liters of oxygen via the non-rebreather mask and also elevated the head of the bed. For analgesia, we now added the oral morphine, which was given 10 mils for hourly for 2 days, and the IV paracetamol, which was initially given 8 hourly. And then we also later added a fentanyl patch, 254 micrograms for 3 days. We then also inserted the urinary catheter for continuous bladder drainage due to suspected bladder dysfunction from suspected spinal injury. And he was later scheduled for a neuro and orthopedic surgical review on the wards. Next slide, please. Next slide, please. Thank you. Yes, so this is now the hospital course when he had been admitted. So I got the hospital course for his first 3 nights to kind of give a picture of how he progressed from the ED. So on the first day post-admission, he had a fair night, and his main complaints were chest pain and mild difficulty in breathing, as well as a productive cough with abdominal pain, which was more marked in the right flank. When we checked his vitals, they had improved and was stable. And he was now 96 SpO2 on the non-rebreather mask. On examination, he still had reduced air entry on the right lung field with occasional crackles and abdominal tenderness marked at the right flank. So our plan at this time was to continue the oxygen therapy and the pain management with fentanyl and IV paracetamol. He was also given antibacterial due to the productive cough, and also he had earlier mentioned that his CBC was normal, but there was actually a neutrophilia. And then he was given rabeprazole 20 milligrams OD and oral morphine, yes, as we had said earlier. Then on day 2, he had his ortho review, and the complaint was pain in the back, chest, and abdomen. And the significant findings were in the musculoskeletal exam with an Asia grade of D, which is to assess the spinal injury or the dysfunction that's caused by the spinal injury. And then he had tenderness on his right lower region of the rib cage and equal bilateral chest expansion this time around. The ortho surgeon also noted the impression of the fractures from T7 to T10 with the lower end plate of T10 involved. And the plan at that point was to continue analgesia and do the abdominal ultrasound as well as continue treatment. Then next slide, the final day was a spine review where the concern was suspected vertebral fractures, and he had a back pain which had now reduced to 5 out of 10. And he had no motor sensory deficits after the fall and still had control of his bowel and bladder. So on examination, he was able to sit in bed and stand with minimal pain, which had improved, and he had mid-thoracic and mid-lumbar tenderness of the abdomen. He's noted his neurological assessment was now Asia A, and then noted spine CT didn't show anything dramatic, but was not in the best quality as reported. And the impression at this point was post-traumatic mechanical back pain, but with stable fractures and muscle contusions. So at this point, the plan was to allow ambulation as the pain allows and still continue the pain control and surgical review for the lumbar abdominal regional pain, and then erect standing thoracic and lumbar x-ray when the pain persists. Next slide, please. Yes, I'll be handing over now to the expert.
Yes, let's invite Dr. Jacob to give us his pearls and pitfalls regarding the management of our patient here. What is the do's and don'ts, the take-home message that you would want to give us? Dr. Jacob, over to you.
Thank you. Thank you, the most immediate past presenter for that course. I think you gave us a time of 3 days after your interaction with the patient in the emergency department, and I must commend you and the team that worked on this patient for the job that was well done. In the management of this patient, like we said, you had raised the bed of the patient. I'm glad that I have seen that the person's pain was well managed. So we dropped by 5 points from the initial complaint of 10 out of 10. Okay, from the paracetamol, we added on some opioids and made sure that our patient was comfortable as regards to the pain, and we did the appropriate investigations and got in the correct people. Now, getting in the correct people means orthopedic and neurosurgery for this patient. My advice, I don't know if this would be a pearl versus a pitfall. Let's see how it goes. But these guys could be called in sooner. As we advance our emergency care, maybe not for his patient, but for some people that come in like this, there are some reversible injuries that the person needs to work on the person within the next few hours. You get me? So they require that these people come in sooner, as opposed to seeing them 24, 48 hours when very little is salvageable. So as we get into systems that work, again, the hospital processes that work, there are those reversible injuries that someone will sustain. And if we delay by another 4, 5, 6 hours, this person will not be salvageable. And as you can imagine, if someone loses their lower limb function and they are 35 or 40-year-old man, they're not able to work, they're not able to fend for their family anymore. So the pearl, I think, there would be that depending on the assessment of this kind of patient, that we have to call in the consulting service, the person who is supposed to help this person next, depending on the judgment, to come in sooner than later. I see we gave the patient some corticosteroids. Yes, now this has been common practice around everywhere for spinal injuries, especially traumatic spinal injuries. But as you can imagine, when people first fell sick of malaria, they were told, oh, it's because you're breathing bad air. That's why it's called mal air. So you're breathing bad air. But evidence shows us that it was actually a mosquito that was carrying down a parasite, and it was injecting it in you, and it was growing, and you were developing signs and symptoms of malaria. So evidence makes us change some practices, makes us change some views that we have about some injuries. So evidence is going towards the side of not using these things. Some people still use them, but it seems not to have any effect on the person's outcome on using corticosteroids in these patients. It actually seems in some studies to show that it actually can be detrimental to the person, could increase length of stay in the hospital, could have some particular outcomes that are not the best. Okay. Yes, so those are so far 2 points. I just wanted to also hint on the spine board. Yes, the spine board could cause some effects that we do not want. But earlier on, and I think I forgot to comment on this, one of the people who questioned at the point of the pre-hospital presentation said, oh, wouldn't we have just intubated this patient instead of putting on a cervical collar, which has harmful effects? And that is correct, that the cervical spine can have harmful effects. And I think the one that you noted was airway compromise. There are things of possible aspiration. Okay, there are things of the ulcers that could happen with these pressure points of a cervical collar. We could even increase this person's pain by using a cervical collar. But you must keep in mind that what is the next option that it is, and most of the things that these people are recommending, or let us not use cervical collars in pre-hospital, are based on opinions. Yes, and I'm not saying that opinions are not to be taken, but you must take that with a bit of your own independence of mind, but also depending on the practice that is happening in the country. Because it would be quite unethical with a person who has an altered mental status, or for example, say someone fell from a building when they were intoxicated with some alcohol. Oh, this guy fell cutting branches, and you feel he can't actually move his lower limbs, okay? And he's having possible neurological deficit, yeah? And if you did a log roll and you find that he has some spinal tenderness. So the risk and benefit of putting that cervical collar usually outweighs the risk of letting that person's neurology go forward. It's not that these cervical collars do not have the effects that I had stated earlier, they do, but you always have to reassess each patient in front of you. Okay, the cervical board is what we have strong evidence on, that once you've used the person to transfer them from the ambulance onto the bed in the emergency department, please put it off, because it is not helping anymore and it will be causing more pressure sores, more problems. And if you're transporting someone, not good, transport them on for a very long time. Okay, so that is where we may say with certainty, or not do this. But the cervical collars, you must take it with a little bit of salt when you're actually planning to use them. You get me? Okay, and I feel I'm speaking a lot, but just to summarize, from the last point I've said, cervical collars, take it case by case, but most of the people in the pre-hospital, once you feel neurological disorder, deficit, altered mental status, please put the cervical collar. Okay, move the patient, because the risk of trying to intubate that person, there are maneuvers you will have to make, and many of us here who are doing pre-hospital may be familiar with the term inline stabilization of the cervical spine when you're intubating. And not very many people, you may not have the logistics of doing that in the field. So you may even worsen the cervical injury. So you have to be relatively careful with that decision. If you're able to transport them to an ED, please do that. Corticosteroids, let's read around it, but the evidence that is saying is that it may cause more harm than actually good, and may not give us benefit. Okay, and these people who we are consulting for these different injuries, we should remember the emergency department when to call them in. Do we wait for them to come in 24 hours, 48 hours later? And I know there are challenges to this, because some of these people come to places and the consultant may not be around, but you must be aware of this, that, this person actually would need this person's urgent review now, because you, as the emergency provider, are the communicator for the patient. You're the person's advocate. So you're going to have to tell them, I need you in the emergency department right now. Okay? Yeah, so I think that is the current pitfalls and powers that I have for this case. Thank you to the presenters.
Thank you very much, Dr. Jacob, for that well-articulated and elaborate explanation for our patients that really come to the emergency departments. And I urge everyone that in your different facilities and where you're going to practice in future, there is silent protocols that we normally have in our hospitals that you need to activate as early as possible, because this helps the patient fast and saves the health worker, because we are moving towards where patients are more informed actually about litigation. And so we need to learn how to protect ourselves. It's just 5 minutes to the top of the hour. I stepped in as the co-moderator. I'm Daniel Olinga, the emergency physician. And we shall then move on just to the brief key highlights of the case, and just understand some more about the trauma in this patient. Thank you very much. Joseph, over to you.
Yes, hello. Thank you. So for the case highlights, yes, this was NR, 48-year-old male who received with a history from a fall from a height with associated inability to walk and severe back pain and he had a provisional diagnosis of spinal injury. So it was also a multiply injured patient, just to give us a wider picture that wasn't only in the spine. And so we needed to do a full workup through the ATLS framework. So the key areas we're looking out for here from the ATLS framework are the circulation, breathing, and the disability. And the conditions, possible conditions that could have raised from these are the spinal shock, cardiac tamponade, then lung contusions or lacerations, which could have dramatic or fatal events which could quickly precipitate to death. Yeah, so we have to prevent these. Next slide, please. So the take home for that I saw in this case and that I thought was important for us to share about is spinal shock. And so this is briefly defined as a temporary physiological state following an acute spinal cord injury in a trauma characterized by sudden loss of all spinal reflexes, motor, sensory, and autonomic function below the level of injury. And it can last from hours to weeks with different phases which are progressing from areflexia, where there is no reflexes or hyperreflexia, and then to reflex return, and eventually even hyperreflexia or spasticity. Next slide, please. So some of the presentations key features that we would look out for in spinal shock are one, flaccid paralysis, where there is like hypotonia in the areas below the area of spinal injury, and then you can have complete loss of sensation in these same very areas and absence of reflexes below the injury. And then also importantly, as I had said, in the circulation, we can have autonomic instability like hypotension. So we have to check our vitals and check the BPs and also the heart rate. So we can have bradycardia and also hypothermia, because some of these are mastered by and controlled by the spinal reflexes. Then you can also have loss of bowel and bladder function when it's a lower spine injury, and respiratory compromise in high cervical spine. And so for the immediate management that we would have to look at, we would have to prioritize the ABCs, just like we did in our primary survey. And then we also have to focus on spinal immobilization to reduce further spine injury, and also high dose corticosteroids. Though, as we had seen earlier, it's a plus or minus. And then we have to support the vital functions in case they are compromised. Like, for example, the blood pressure, we can have neurogenic shock from the spinal shock. So we need to maintain the vasoconstriction or the peripheral vascular resistance with the vasopressors, and also mechanical ventilation in the case that the patient cannot breathe on their own anymore. And then bladder catheterization and ICU monitoring with a multidisciplinary team is vital until the patient's basic reflexes return. Yes. So these were the references that I had. And thank you.
Thank you very much, Joseph. And everyone, just stay with us for a bit, because there is a survey that is just coming onto your screen right now. If you can just submit your answers to those questions, it would be lovely, because at CPC we are just not here to deliver basics about knowledge. We are advancing emergency care, and to you, the students and practitioners all over the country, Uganda, the region, East Africa, and globally, because we normally have practitioners all over the world who attend the CPC cases. And in the pipeline, with your feedback, we are also working on a podcast. This podcast is going to go global. We shall soon be launching it again. Emmanuel and we, the Secretariat at CPC, are working round the clock to ensure that this is something that we are all going to enjoy. And the numbers are impressive. They keep rising. So please tell one to tell a friend to tell the other that CPC is here to make life simple for you. And we are glad that you are all participating in a lovely manner. To our panelists today. Allow me to appreciate Joseph for the lovely presentation that you have given unto us. We really do appreciate your efforts and time put through for this. Kusewewo, I also am glad, pardon my present pronunciation of your name, but yeah, it's so glad to have you in the pre-hospital team. And the evergreen Dr. Jacob, gladly on purple, he loves to tuck in always, and his knowledge is always tucked in. I hope all the students who came in today have actually packed and tucked in the knowledge that they have gotten today about these cases. These cases come in numbers, and the more you learn and practice on a daily, surely you will own up your patients and save more lives. We are 1 minute past 8 p.m. Our sessions are normally 1 hour, and we are glad we kept time. Please keep the polls rolling. I still have over half of the team to just, fill in this survey. Your feedback is very important for us. And we love you all at CPC. And we are planning for Christmas party. So if you see an invite coming to you, be certain for sure that it is all for the great good. Thank you very much. And to our audience, you have always been lovely. We are tracking the people who have been consistent with us, and packages normally come along the most consistent attendees. Even those who clap, we are tracking you. Harry, we are tracking the claps that you're giving us as we are completing the poll. All right, so at this point, as many people have polled so far, allow me to wish everyone a lovely night and enjoy your weekend. Happy Friday. Let's meet in places where we are cherished. Adios.